Good morning, everyone. It's our pleasure to welcome Dr. Sanjay Kumar Date. He's MD in pharmacology. He has done his PG diploma in marketing and sales. He has over 23 years of academic experience and around 20 years of pharmaceutical industry experience. Uh, Being a doctor, he has overall experience of academic experience of 23 years, and for 11 years he was working as professor and head in department of pharmacology. Out of that, 8 years in the Sumandip, and then he joined our hospital PIMSR. Before that, he was in pharmaceutical industry for 20 years. He was for 6 years. He had experience in pharmaceutical industry as general manager, medical services in Alembic, and 3 years as medical director in clinical trials. He was working as a general manager, medical devices, looking after the marketing of the medical devices for 14 years. His major areas of interest are diabetes mellitus, cardiovascular diseases, and neurobiology. So, without wasting much time, I welcome Dr. Sanjay Date, and I request him to share his knowledge about the current management of Parkinson's disease. Over to you, sir.
Right. Good morning, everyone. I first thank Dr. Archana Navale and the team for giving me this opportunity to share some of my knowledge as well as experiences in the area of Parkinson's disease. Um, I have been associated with Parkinson during my sojourn at Medtronic, which is a medical device industry. It's a leading multinational, American multinational, primarily into cardiovascular area, producing stents, heart valves, pacemakers. And I looked after that also for a while. But when the neurology division came up, I was the head of neurology there. And there we had launched for Parkinson's disease a procedure called deep brain stimulation. And that helped me to interact with several neurologists, neurosurgeons, and we did about 500 deep brain stimulation procedures with the hospital teams of neurologists, neurosurgeons, and other hospital staff, radiologists, and stuff. So that has given me an added insight into the disease, and apart from my regular, of course, mainstay. Sorry. Apart from my mainstay, training in pharmacology as a pharmacologist, and whatever I have learned in Parkinson's treatment of Parkinson's disease. So, without much further delay, I would start the topic, which is entitled Current Perspectives of Management of Parkinson's Disease, which means how the total disease is managed. Of course, the major focus with this group will always remain the pharmacology or the drugs. So let's begin. So are you able to see the first slide? Hello, someone will have to respond.
Full part of the slide is visible, sir. Please scroll down.
So current perspectives of management of Parkinson's disease. Now let's for that look at Parkinson's disease. Now, as the heading suggests, the name of the disease is after the person who described it first, and he is James Parkinson, 1817, and this is one of the two major central nervous system degenerative diseases which afflicts humanity. The other one is Alzheimer's. So Alzheimer's or dementia, where there is total loss of memory, progressive loss of memory, uh, and is a disease of a later age. But the Parkinson's disease is uh, a degenerative disease, specific areas of the brain, and that occurs earlier in life. So let's look at how it occurs or why it occurs. Etiology. This is a syndrome of varied etiology. The most common is idiopathic, where there is no other cause can be pinpointed. The other one is, and this is the commonest, the other one is arteriosclerotic. Now, what does it mean? All of us, right from birth to death, our arteries as a child are very elastic and responding very well to blood pressure, and slowly they start hardening, and this process is called as sclerosis. So this happens with everyone. So that is the reason why, as the age advances, you will the blood pressure of an individual would rise. But of course, if it goes into pathological area or beyond a point, then we call it hypertension. But otherwise, not. Similarly, arteries of the brain, everywhere, they will start sclerosing and hardening, which results in lesser blood supply to the area and makes help in the degeneration process. Next cause is post-encephalitic, or when there is a encephalitis or inflammation of the brain by usually virus. Encephalitis is usually by virus, and after that you may for some time have Parkinson's-like syndrome. The next cause is Wilson's disease, or also called as hepatolenticular degeneration. Am I audible loud and clear to everyone? Everyone is understanding? Okay, good. So Wilson's disease, there is also a copper deposition in liver cells, and then also there is a lens or eye lens copper deposition, and also there is a Parkinson's-like. So this is a whole syndrome, Wilson's disease. Again, a very rare disorder. Then there are several drugs which antagonize dopamine. Essentially, as I said, it's a dopamine, Parkinson's a dopamine deficiency syndrome. So apart from the degenerative or idiopathic, there are also drugs which antagonize D2 antagonists, reserpine, haloperidol, phenothiazines, the typical antipsychotic drugs which work by dopamine antagonism typically produce extrapyramidal syndrome as a major adverse effect. And that is the reason for the discovery of atypical anti-Parkinson drugs, atypical antipsychotic drugs, which do not have this problem. But yes, these typical antipsychotics can produce Parkinson-like syndrome or symptoms. Then environmental toxins, methyl phenyl tetrahydropyridine, short formed as MPTP. And we can produce an animal model of Parkinson's disease by using MPTP in the animals. So environmental toxin plus aging process in human being and and oxidant attack by various radicals may result in Parkinson's. But as I said, the major part of the disease or the major form of the disease is idiopathic, where you cannot find any obvious cause, or what is otherwise in other diseases also called as primary, you know. But somehow we have chosen not to call primary Parkinson's. It is like primary hypertension or essential hypertension, but it is without any cause. And other causes, as I said, have been mentioned as above. Now, how often? It is usually 2% of people suffer from above the age of 60 years suffer from Parkinson's. As we saw during the early part of the millennium when I was working on this, that younger and younger people have started coming into the net and getting affected, sometimes even starting as early as 40. So that's really scary if a neurological disease starts at 40. So what happens actually? Let's look at pathophysiology. So how we develop this disease? As I said, primarily it is dopamine deficiency in the brain. If you are aware, must have been taught the major neurotransmitter in the brain is GABA, gamma amino butyric acid, which is an inhibitory transmitter. And all the drugs which we make and use, for example, a sedative hypnotics or anti-epilepsy, all are working through GABA. Yes, but the second important one is dopamine. And dopamine is present in the basal ganglia or overall basal ganglia, substantia nigra. These are the structures in the midbrain, and these are a part of extrapyramidal tract, extrapyramidal motor tract. So what is this pyramid? The normal pyramid is your normal motor tracts coming from the brain, crossing over into the spinal cord and then supplying all the voluntary muscles. But this extrapyramidal tracts are the tracts which help you or human being in associated movements. So what are these? They are skeletal muscle movements, but these are associated movements. So what do you understand by that? See, when I want to hold or pick up something or slap somebody or caress, I can do it voluntarily with my hand, commanding my hand muscles to do that. But when I walk, I don't ask my hands to move, but my hands move automatically. When I think of something beautiful or have a good memory, my muscles of the face automatically go into a very nice face shape. When I have nostalgia, again the facial muscles would act automatically, form in such a manner that people looking at me will say, oh, you are remembering something beautiful. So all this is the associated movement or involuntary associated movements of the body, the hands, legs, face, that is governed by the extrapyramidal extrapyramidal tracts, and they are governed by dopamine. So, understood this basic thing? The involuntary contraction of skeletal muscles is based on the extrapyramidal tracts. Very interesting. So far you must have heard that there are only two types of muscles, that is skeletal muscles which are voluntary, and indeed that is true, and the smooth muscle of the viscera which are involuntary under the control of autonomic nervous system. But these are the this is an extra special tract, extrapyramidal tract governed by dopamine, which although the skeletal muscles are contracting, but they are not under your control. They are automatically doing according to the main task you are performing. So enough is enough for this is what why I'm telling you all this is to understand some symptoms. So we'll come to the symptomatology later. So let's look at that as whatever I have described. Now I'll read. So dopamine deficiency syndrome affecting the extrapyramidal system, which is responsible for associated movements, facial expression. Also in the disease there is increased GABAergic activity, and GABA being a negative or inhibitory neurotransmitter, there is less movement or say rigidity, akinesia. Yes, you can want to, you can interrupt and ask question, or maybe at the end you can do that. So also there is a relative excess of acetylcholine. So dopamine is less, but acetylcholine is more. The disease is progressive, and unfortunately it is incurable. So then let's look at basal ganglia containing dopamine associated with all the associated movements. It's substantia nigra, putamen, globus pallidus, and subthalamic nuclei. These are the major areas where dopamine is available and it functions for the extrapyramidal tract. Now when disease occurs, these dopamine producing cells, they degenerate, and the clinical symptoms may not appear till 80% of dopamine gets depleted. So body has a lot of reserve. So even if degeneration starts, but still the body will keep on doing its functions normally until a good 80% degeneration occurs. So that's a good protection, but after that, of course, it is horribly progressive. Usually it starts on one side, say a hand tremor or a leg, akinesia, rigidity, and eventually becomes bilateral. The symptoms include tremor with typical pill rolling movements of the hand, fingers, rigidity, brady or kinesia or slow movement, akinesia or no movement or patient is frozen, and fascinating gait. Because of akinesia, patient is unable to lift his foot completely, so he sorts of drags his feet, and the gait is typically called as fascinating gait. And since his face is unable to give any expression because of inhibition or lack of function of as I explained, you are feeling good, bad, jealous, all these make your facial expressions to change. But that will not happen, and your face will become, your means patient's face will become mask-like. So there is a mask-like face, no expression. The cholinergic preponderance results in symptoms like cyalorrhea, excessive salivation, or excessive sweating, seborrhea. Okay, now these are the symptoms, signs, primarily tremor, akinesia or bradykinesia, and rigidity. Setting up after the age of 60, 2% people, degenerative disease, dopamine, basal ganglia. So these are the key words of what I have already taught and will keep recurring. So take a note of these. And now we come to the management. The total management, which I will cover the medical, which is the major, and I will add the surgical treatment. So what are the aims of therapy of Parkinson? You are not going to cure it. So relief of tremor, rigidity and akinesia. When this occurs, there is increased confidence. Then second aim is to correction of mood changes, which are due to frontal lobe dysfunction. This may or may not lead to intellectual disability. In fact, some of the Parkinson's patients I have seen are very, very sharp and with good memory. So depression is usually seen with arteriosclerotic variety, but sometimes there is progressive dementia or loss of memory also. Rarely, but it can happen, which will be the most unfortunate. So other aim is to treatment of other symptoms like sialorrhea and seborrhea. Okay. Treatment of cause. So idiopathic, there is no cause. But if suppose it is drug induced, which is the only one which is the most amenable to correction. So in antipsychotic drugs, if we withdraw the drugs, the Parkinson symptoms are reversible. Otherwise, in idiopathic, they are not reversible. Okay, so aims of therapy. Now modes of treatment: drug therapy, supportive treatment including physiotherapy, and surgical treatment comprising of lesioning or creating lesions in some areas of the brain, and of course deep brain stimulation. So let's look at them. Major, of course, is the drug therapy, and you are primarily concerned with this. So let's look at the drugs. Obviously, it is all dopamine, all dopamine. So if dopamine is less, increase dopamine. For example, in diabetes, insulin is less, make insulin more effective. Or add insulin from outside, inject insulin. Same way here, make existing dopamine more effective, more than that, prevent destruction of dopamine, and so on and so forth. So let's look at the drugs. Drugs that increase levels and activity of dopamine in the brain are dopamine precursors, levohydroxyphenylalanine. Levodihydroxyphenylalanine, or the levorotatory form of dopa, dihydroxyphenylalanine. So if you can recall your synthesis of catecholamines, it starts with the basic essential amino acid in the brain called phenylalanine, and then it is hydroxylated twice to become dihydroxyphenylalanine, and that is dopa. So from there, of course, we decarboxylate, get dopamine. From there, we get adrenaline and noradrenaline in the body. So similarly, this levodopa can be administered from outside, which results in formation of dopamine. Then dopamine receptor agonists like bromocriptine, ropinirole, and pramipexole. Drugs which prevent dopamine destruction. Dopamine is destroyed by two enzymes, which is a monoamine. So and also a catecholamine, so it is destroyed one monoamine oxidase, MAO-B, which is in the brain. So MAO-B inhibitor selegiline, then catechol O-methyl transferase, COMT inhibitor. This enzyme also metabolizes catecholamines, and the two COMT inhibitors are entacapone and tolcapone. And next is the drugs that release dopamine, amantadine. So all this increases dopamine. And the second part is the cholinergic axis. So drugs that block cholinergic activity, which are atropine and atropine substitutes. The atropine substitutes are benzhexol and benztropine. I'm sure you have heard and read about them as part of atropine substitutes, which incidentally help in so many areas, starting from brain to all over the body by blocking muscarinic receptors. Alright, so these are the two major groups. So let's look at them one by one. The cornerstone, as they call it, of Parkinson's disease therapy is levodopa. It's a prodrug. Are you all guys with me?
Yes, sir.
Very good. Because all this online stuff is like a andha kuan. So you can only hear your own echo. Otherwise, there is no feedback to know how you are going, where are you going. Aankhein band karke groping in the dark. But anyway, that is, there are advantages of this because you can reach out to large number of people, and in the corona it has become very popular. So coming back to levodopa, it's a prodrug, gets converted. Prodrugs are, as you know, drugs which are otherwise not effective, but in the body they get metabolized to an effective active metabolite. So prodrug gets converted to dopamine by action of dopa decarboxylase. So as it is a dihydroxyphenylalanine, an amino acid dihydroxy. So you decarboxylate the acid and you get the amine, and that is dopamine. So dopamine levels increase in the brain, and it is so dramatic response initially that it confirms the diagnosis of Parkinsonism. Otherwise, there can be many. I was also thinking of sharing a differential diagnosis, but then I thought that will be going too much into internal medicine, which probably you may not be that much concerned with. So there are many syndromes, neurological, which may mimic the Parkinson syndrome, and that's why, just to be sure about the diagnosis, we can give a DOPA test. So if the patient on 1.2 grams of levodopa for 3 months does not show any improvement, then probably the physician or neurologist is not dealing with Parkinson's disease. It is something else. So it is so diagnostic. So very, very effective. Dopamine is needed in the CNS. So now this levodopa which you are giving, dopa decarboxylate is also there in the periphery. So what happens is, if you give levodopa in the periphery, dopa decarboxylase may or will convert it to dopamine in the periphery in your, so which will immediately start acting on the CVS and other actions, and it will not cross the blood-brain barrier easily. So very little of what levodopa you consume may reach the brain where it is needed, है ना? So blood brain barrier cross होने के बाद वो decarboxylase हो तो अच्छा है, and that is why levodopa is always given with carbidopa. And what is carbidopa? It is dopa decarboxylase inhibitor. So when you take levodopa and carbidopa together, the carbidopa will prevent destruction of levodopa or conversion of levodopa to dopamine in the periphery. Carbidopa will not enter CNS. Levodopa will. So more levodopa will enter the CNS, and there you get release of dopamine by dopa decarboxylase. So then you will get dopamine there. So usually levodopa and carbidopa is used in a ratio of 10:1. So say 100 mg of levodopa to 10 mg of carbidopa. Let's look at some of the actions of levodopa. These are simply the actions of dopamine, because it is nothing but dopamine prodrug. So in the CNS, what happens, where we are really interested? Normally levodopa will act on patients and not in normal individuals. So if you and I take levodopa, nothing will happen in the brain because we already have enough dopamine. But peripherally, definitely we will have dopamine actions like on the heart rate or blood vessels. So in CNS, action seen on patients, not in normal. So first to respond is akinesia. Akinesia responds. The movements become better. Rigidity also patient becomes better. Tremors is reduced. Seborrhea and sialorrhea and aphonia are reduced. Phonation, the patient is for Parkinson, one of the symptoms is phonation is reduced. He is unable to speak loudly. So that may improve. The another symptom is micrographia. So the handwriting also become very small. So whenever we do therapy, we also ask the patient to write down. So we see actually improvement in his magnitude or his font size also improves in his handwriting. So also improves memory and mood, makes patient more interested in surroundings. Also relieves idiopathic dystonia in children and adolescents. Coming to CVS, through release of dopamine, levodopa has positive inotropic action, that is increased force of contraction. Large doses can cause rise in BP through alpha receptor stimulation. Through dopaminergic receptors, renal and mesenteric blood vessels dilate, which causes a fall in blood pressure in small doses. So these are typical dopamine actions in the periphery on the CVS. Hello?
Yes, sir.
Yeah. So next point is endocrine actions. As we all know, dopamine is nothing but prolactin inhibitory hormone. So pituitary produces prolactin, which helps in lactation, and the hypothalamus commands the pituitary through a prolactin inhibitory hormone, which is which is dopamine. So dopamine inhibits prolactin secretion. And that's why, just to correlate, when you use antipsychotic drugs, there is also patient suffering from galactorrhea amenorrhea syndrome. And why there is galactorrhea or excessive lactation? That is because normally the antipsychotics act through dopamine antagonism. So dopamine is inhibitory for prolactin. So inhibitory is inhibited, that means prolactin is increased, that's a galactorrhea. So endocrine actions of dopamine is to inhibit prolactin. So these are other actions. The main, of course, we are concerned with Parkinson's, which it improves all the symptoms. Levodopa undergoes rapid absorption, peak is half to 2 hours, and plasma half-life is 1 to 3 hours. Usually levodopa is taken thrice a day. Only 1% levodopa penetrates the CNS where it is to act. Also pyridoxine, D6 vitamin accelerates peripheral decarboxylation. So vitamin supplements are to be avoided, especially those containing pyridoxine, when the levodopa treatment is going on. But of course, to increase penetration, and we are using carbidopa. Adverse effects of levodopa on GI: nausea, vomiting, anorexia. There is a CTZ stimulation, chemoreceptor trigger zone stimulation in the brain, which is minimized by increasing the dose slowly and adding carbidopa 25 mg TDS. Behavioral confusion, agitation, delusion, hallucination. Levodopa can exacerbate psychotic states. In CVS, there can be postural hypotension and palpitation because increased force of contraction. CNS, it can cause abnormal movements, choreoathetosis, and dyskinesias, often which are incapacitating. As we go further, we will know that as we keep on increasing the dose of levodopa, after about 8 to 10 years, what happens is that a patient starts getting dyskinesias as a toxicity of levodopa. Provides good control of symptoms in most patients for 8 to 10 years. Dose is 250 mg tablets, levodopa plus 25 mg carbidopa. Also 100 levo plus 10 carbi. We can go as high as 500 mg levodopa plus 50 mg carbidopa. Tablets are also available by the trade name of Sinemet. Maximum dose is 2 gram daily. On levodopa, there is on-off phenomenon. What is on? When the patient is showing good effect of levodopa, his rigidity is less, he is talking well, is moving around. And off is before the next dose is due, the patient may become totally rigid or frozen, and it is clear that the drug effect is off. This is called on-off phenomenon. Dyskinesias develop after this 8 to 10 years. So patient alternates between on, where he is active with dyskinesia. Unfortunately, I would not be able to show the video because it didn't come onto the mobile. I didn't have it in the mobile. But if the patient actually just cannot even sit in his chair, he just keeps moving when the effect is on, dyskinesia. And when patient is off, he is totally frozen. So that is the unfortunate part. Now this is the time when probably he needs surgical treatment, which is in form of pallidotomy, thalamotomy, and deep brain stimulation, which we will take later. The next drug is, I have already dealt with, dopa decarboxylase inhibitor. By themselves, no action. Concurrent administration of DDI, which does not enter CNS, helps maintain levodopa levels going into the CNS. So we have already discussed this. Carbidopa helps reduce levodopa dose by 75%. Nausea, vomiting, and other dopamine effects are reduced by carbidopa. Control of symptoms is smoother, and large fluctuations are avoided. The other dopa decarboxylase inhibitor is benserazide, which is used in proportion of 1:4. The next group is dopamine agonists. First is ergot derivatives, bromocriptine, pergolide, and cabergoline. These are now less used. They were the earlier times. The newer ones are ropinirole and pramipexole. Bromoergocriptine is a synthetic ergot preparation, D2 agonist, crosses blood-brain barrier. Maximum dose is 20 to 3 milligram per day. Main effect, because it is nothing again but dopamine agonist, so cause nausea. The other newer ones, dopamine agonists, are ropinirole, stimulates dopamine receptor, have longer duration of action than levodopa, better tolerated, less nausea, but main adverse effect of ropinirole as well as pramipexole are sleep attacks. The patient on these two drugs may suddenly fall asleep, so they should not be driving or working near machinery. But often when levodopa dose is too much, then you can use these drugs to reduce this dyskinesias caused by levodopa. So these are the agonists. Then drugs which prevent destruction is MAO inhibitor, selegiline. MAO A is in periphery, MAO B is in the brain, B for brain. So this metabolizes dopamine. So inhibitor selegiline is selective irreversible MAO inhibitor given along with levodopa. It increases the concentration and storage of dopamine within the basal ganglia and striatum, prolongs duration of improvement by levodopa. There is also a reported neuroprotective effect from the derivative D-methyl or desmethyl selegiline, which is a metabolite of selegiline, active metabolite. Adverse effects: increased dyskinesia, nausea, and hallucination. Dose 5 milligram BD, breakfast and lunch. So when you use along with levodopa, levodopa is given breakfast, lunch, dinner, while selegiline is added at breakfast and lunch and not in dinner. The COMT inhibitors also prevent destruction of dopamine. The tolcapone and entacapone. Tolcapone is not used now because adverse effects, especially hepatotoxicity, was predominant. So entacapone is the only one used. So these two groups increase levels of dopamine by preventing destruction. Now drugs that release dopamine, as the proverb goes, flogging a dead horse. डोपामिन है नहीं और आप उसको रिलीज करवाते हो, पर फिर भी if the patient is totally frozen in an emergency, then you can use amantadine. Amantadine is basically an antiviral, but in also has an antiviral effect, but basically it releases dopamine, so reduces akinesia, rigidity, and tremor. Releases dopamine from residual nerve endings. Dose 100 milligram BD. Therapeutic efficacy just 15 to 20% of levodopa, but response is more rapid. Other drugs, anticholinergics, as I said, for seborrhea, sialorrhea, benzhexol, also called as trihexyphenidyl, is a synthetic atropine substitute, controls rigidity, tremor, sialorrhea, seborrhea, affects mood favorably. 2 and 5 milligram tablets. Dose is 2 milligram per day, slowly increased to 10 to 15 milligram. Other similar drugs are benztropine and bicaridine. So anti-muscarinic or atropine substitutes useful in brain or Parkinson's disease. Antihistamine, diphenhydramine, a strong sedative antihistamine, or phenadrine, promethazine again, a strong antiemetic, sedative antihistamine, promethazine. These control acute drug-induced dystonic reactions and also have a strong anticholinergic action. As we all know, antihistamines, many have a strong anticholinergic action. So they reduce secretion in two ways. We all know this. One by direct antihistaminic action and another by strong anticholinergic action. So there we go, drugs over. So in the interim, if you have any questions, you can ask about the drugs.
We will take questions at the end, sir.
All right, so that will be soon. Because now I come to the surgical treatment, that is for the sake of completion of, because the title is management. So management is primarily by drugs, and as I have been telling you, the mainstay remains levodopa. Levodopa alone can be after some time toxic because of excessive release of dopamine alone. But in any case, there is no win situation. After about 8 to 10 years of drug treatment, primarily with levodopa, sometimes we can add ropinirole or pramiprazole as dopamine agonist, or add saligerine as MAO-B inhibitor to prevent destruction. All this increasing dopamine levels. But as I said, there comes a time when the patient on the drugs is either totally on with dyskinesias. So he's on, but cannot even sit in his chair. Most involuntary movement, dyskinesias take over, and when it's off, that is no effect of levodopa or dopamine enhancers, then the patient is frozen, just cannot move. So just cannot move. At this point of time, patients or his relatives may consider surgical treatment, which is in two forms. One is lesioning. Lesioning means we do a procedure of radio frequency ablation, and ablation means destruction or removal. So what is done is in the brain or in the basal ganglia there are nucleuses called globus pallidus, as I told you. Destroying global pallidus is called pallidotomy, and destroying subthalamic nucleus is called thalamotomy. So radio frequency ablation, relatively cheaper procedure. Of course, neurosurgeon will also charge heavily for procedure anyway, but there are uh, no devices involved in this, and it is irreversible. Once the area is destroyed, it is destroyed. Um, so that is palidotomy, thalamotomy. It can be unilateral, that is on one side, but often since the disease is bilateral, so we'll have to do bilateral thalamotomy or palidotomy. This causes improvement in symptoms, but it is destructive procedure, often needs to be done bilaterally. But then, as I said, I was involved in this deep brain stimulation where we don't destroy. Um, what we do is stimulation of globus pallidus and subthalamic nucleus. Now, increasingly, globus better results are found with the stimulation of subthalamic nucleus. So all symptoms are reduced, and we also can have reduction in levodopa requirements. Briefly, the procedure is we do craniotomy, that is, we have a hole aside the midline uh, on the sagittal suture, midline of sagittal suture, or in the center of the occiput, not the back, but on the top of the head in the center sagittal fissure. Just on the right side, on both sides we have holes, and we deploy the surgeon, the neurosurgeon, with the help of a radiologist, deploys a lead which goes straight into the subthalamic nucleus. How this is possible is that the patient is put on a stereotaxy frame on the head, and the radiologist already has worked out, before patient has gone into the operation theatre, the radiologist has worked out XYZ axis. That means in the MRI, where very high resolution MRI is used, 1.5 Tesla MRI, and there on the MRI we have plotted that how much deep we have to go, how much lateral we have to go, and how much deep sideways, and how anterior posterior. So X, Y, Z, all axes are plotted on the stereotaxy frame. The frame is put onto the head of the patient. Patient is conscious. Craniotomy is painless, and then the leads are put inside. Often also one advancement is microelectrode recording, where each area of the brain has specific electrical signature. So as the lead keeps on going in, we know where we are, or the surgeon knows. And once he reaches the subthalamic nucleus, there is a typical graph on the computer, so we know we have reached there. And then the lead is externalized, and through the neck, below the clavicle, one pacemaker is put, which gives the electrical stimulus. And that electrical stimulus can be programmed, usually anywhere from 1.5 volts to 2.5 volts signal is given. And of course, then the patient comes out. During the surgery also, the person is conscious, and the surgeon can ask him to touch his nose and move the nose away, or sign, or pick up a glass, by which the symptom improvement is so obvious. Later on, the pacemaker is programmed from outside, and correct amount of electrical stimulus is given through the lead to the subthalamic nucleus. So this is the procedure. Battery is programmable to give current customizable to the patient need. So very highly sophisticated procedure is there, but that is the last resort. Unfortunately, the operation is expensive. The hospital finds it very expensive to have a you know as high resolution MRI and also the stereotaxy frame. So despite this, we were able to do 500 procedures at least till I was there in about for 5 years with this procedure. But it was always an uphill task because it afflicts an old person, which is usually not productive. That is also not earning. And that is the reason there are very few procedures happening all over the world, despite refinements and good results. Um, so this is surgical. Um, this is happening in a few centers in India, about 8 to 10 of them. But apart from that, the mainstay is levodopa and other drugs, and unfortunately, degenerative disease, progressive disease, um, and like many other neurological diseases, not very rewarding to treat. So there you are. Now, this is the whole treatment of Parkinson's disease. Any questions?
Sir. Yes, sir. I will ask my question first. Uh,
Yes.
so I have seen with mild or moderate cases of Parkinson's disease, there is a lot of confusion with the diagnosis because they would say that this is associated with some uh, senile degeneration or anything like that, and they
Yeah.
don't start levodopa for mild to moderate cases. They give benzhexol. Is
Yeah.
there any objective test, which may tell whether yes, this is Parkinson's disease or not for sure?
Yeah, like in starting discussion on levodopa, very good question, and this is definitely a dilemma even with the neurologist. And but it is a very clear test, levodopa test. There is also a kind of a diagnostic test that if on 1.2 grams of levodopa daily, max 1.2 grams, usually there is a dramatic improvement immediately within say a week. But if for 3 months of treatment with levodopa there is no improvement, we are definitely not dealing with Parkinson's disease. So without hesitation, one has to, if one suspects or one has typical symptoms, one must start with levodopa immediately.
Okay, sir. Another I was having a question that because it is a neurodegenerative disease and a lot of research is going on to reverse the neurodegeneration. Uh, are you means do you know any clinical trials or any soon drugs which will be coming soon in this area which may reverse the neurodegeneration? Are there any hopes?
Uh, Actually, it's a very tall order. Reversing degeneration in any area is extremely tough. Yes, you can. There are approaches which can, increase the level of dopamine secreting cells, and the huge hope was initially, due from or happened with the stem cell therapy. So, stem cell therapy, probably all of you know, is where stem cells which are not yet differentiated, it can be from bone marrow, can be from umbilicus, umbilical cord. So, these stem cells which are not differentiated are put into or deployed, so to say, in different tissues, say a cartilage, so that a cartilage would grow in arthritis, or onto the islet cells, so that these cells start producing insulin, or like in the basal ganglia or substantia nigra, you put the stem cells, and it was very much hoped that after some time they will start producing dopamine and reverse the Parkinson's disease. But unfortunately, now we are almost 20 years into the stem cells, but not a single therapy worth the name has really emerged so that it can be, standardized and commercialized, and is without any adverse effects, although it will always be very procedure intensive and skill intensive, but nothing so far. Even the same thing is happening for Alzheimer's, which is probably in the developed countries uh, even a bigger issue, and is also coming to India as we become older and older population. But nothing. Degenerative disease are yet a very lot of unmet need.
Are you aware anything you can contribute?
No, not yet, sir. I have not seen any therapy coming soon.
No. The only hope is stem cell therapy.
Yes. So currently we are having levodopa, which is the most
Yes,
effective drug for
levodopa.
this.
Yes, and dopamine agonists, all these, they help and reduce the levodopa dose.
Yes.
So, but in the end, it is all dopamine. So, एक का डोज कम करोगे, दूसरा भी वही कर रहा है ना, डोपामिन ही बढ़ा रहा है.
Yes.
Yeah,
Ultimately,
dopamine
the
action
target
बढ़ा
is
है.
same. Yes.
हाँ,
I
it is
would
dopamine only.
request if anyone is having questions, they may ask. Okay. So, sir, thank you very much for your valuable time. It was really a great session. We learned a lot of things. Most of the things are there in their BFARM, but still there are a few things which were added with this. Thank you very much for this. Thank you very much, sir.
My pleasure. Anytime.
Thank you, sir.
Okay.
Yes, sir.
So now signing off.
Yes, sir.
It was a pleasure to be with you.
Yes, sir. Yes.
Hope to see you again later.
Thank you, everyone.